Welcome to the Weigh In Podcast, your prescription for a healthier life, where wellness is more than just a number on a scale. We'll dive deep into not just weight loss, but the medical, emotional, and lifestyle aspects of well-being.
In each episode, we'll weigh in on hot topics ranging from diet myths and exercise trends to mental health and chronic disease management, providing you with the evidence-based advice to guide your health decisions. Remember, it's not just about the weight on the scale, but about creating a healthier, more balanced you. Hey, Katie, how's it going?
Good, good. How are you?
I'm getting over a cold, so it's been going around.
There is something nasty going around.
Yeah, but I'm better now. I slept it off yesterday, and I'm much better today. So
good.
Yeah. I read this news article today about Brozempic. There's like all these different variations on Ozempic that I just love. Like we had Ozempic last time.
Ozempic is not at all Ozempic.
Now this is Brozempic.
Oh my gosh.
Basically, it's from the New York Times, and they were just trying to talk about how this one startup called Fella Health is prescribing weight loss drugs to men, but their approach is different because, they're trying to target guys, but, it's hard when they don't want to admit that they want to take weight loss medications. So they were just trying to explain, you got to talk to them at their level. Like, don't be afraid to engage in bro talk. So
what is bro talk?
Yeah. Basically, like their ads say, okay, tired of not hitting your weight goals, big guy? We're not momming you. We're a mechanic. You're bringing in a car that needs to get fixed. Like, try to have some metaphors that they can relate to. But it was interesting. They also stated that in some studies, they found that 51% of women take the weight loss injectables and 38% of men take them. So I found that interesting, which I already knew. I mean, they say that in my own practice. You probably see that in yours. Majority of them are women.
Yes.
And, I've got a handful of guys, but yeah, most of them are women.
For sure. And some of mine are like guys who are the husbands of the women that come in.
Right.
Like, oh, my wife Jane told me I had to come and see you.
Yeah. Or they felt like, okay, if she's losing weight, then I guess I can lose weight.
Right.
Yeah. And then there was another study that found in 2020 that men in Britain, they were put off from using the GLP-1s because they felt that they were outnumbered by women, or that the focus was on praise and the discussion of feelings was just too overbearing for them. They basically just want to focus on just losing weight. Like, it's not a vanity project for them, but it's just harder for them in general to admit that they need help. And then also there's just some shame in society and media about taking drugs for weight loss, which, I mean, I feel like it's also true for women, but I feel like women are more likely to seek treatment for that versus men. I feel like men feel like, oh, I gotta be macho about this. I gotta like work out. I gotta eat better. I don't need to use medication for this. Like, it's a shortcut. So I think, like, for providers, just realizing that we need to talk to them differently than how we approach women, and not to like, make it a whole gender thing. But yeah, some guys just don't want to focus on their looks. So I think overall it's just important to be on their level about it. But there have been some celebrities that have come out about it. For example, Elon Musk, like a couple of years ago, he admitted on Twitter, oh, I use Wegovy. You got Charles Barkley.
Respect. I was happy to see that he came out about that, because so many stars are like, what? I didn't do that.
Yeah, exactly.
Diet and weight loss.
Yeah, and that was around the time where we were suspecting certain celebrities were using it, but he just came out and was like, yep, I'm on it. So yeah, overall, like, when you're approaching men with that want to use GLP-1s, they seem to appreciate it when it's less about their looks. They like it when it relates to having an active lifestyle, or like having a dating life again, or being able to provide for their family. So just something to look out for if you have a potential male client that's looking for weight loss drugs.
That makes lots of sense, actually. And hopefully over time, some of the stigma will decrease. This isn't even one of the news segments that I was going to talk about, but I think it was recently, maybe over the weekend, that Drake posted on Twitter or X or Instagram, I forget which one, but basically he made a comment kind of like dissing Rick Ross and referencing like Monjero making him loopy or something like that. With the take home point being like, you're whack and you take Monjero type of thing. So to sort of add to your point about men feeling like being on these drugs is like a sign of weakness, that's like more proof.
And now it's being used as a diss.
As a diss, yes. All right, so my little news tidbit was about Mama June. Do you remember her?
I don't know who this lady is.
She's Honey Boo Boo's mama. So yes, like, from Toddlers and Tiaras.
Girl. Okay.
Yep. Mm-hmm. Honey Boo Boo's mama. She lost like a ton of weight. I want to say it was like 300 something or pushing 300 something pounds at one point after getting gastric sleeve surgery. But then, not all that uncommon, she regained a decent amount of it back. I think after having a huge personal loss, I think like her daughter passed away from cancer or something. And so she kind of gained some of that weight while she was caring for her. Case in point, she wants to lose the weight now. And she's been very public about the fact that she's now trying semaglutide. So she's doing this about 9 years after having gotten the gastric sleeve surgery. I think it's super awesome that she's trying to lose the weight and that she's going public with it. But it's interesting because I think some people that have had gastric sleeve surgery don't realize that they can take this medication.
Right. Or that they can regain the weight back too, you know? So, wow. So did she specify she's using semaglutide and not Ozempic?
Ooh, good question. I don't know. It's interesting. Yeah, we'd have to look and see. I don't know. She's doing semaglutide versus Ozempic. I'm sure that she'll be pretty open about it because it sounds like she plans on sort of detailing a lot of this journey. The other tricky thing about this is people kind of use them all interchangeably, which I know Novo Nordisk does not want people to do. Novo Nordisk would like for us to say if it's semaglutide or is it their brand name. But I think especially lay people, it's like, I don't know, it's either all Ozempic or it's all semaglutide, you know what I mean? So I think it's kind of hard to tell.
That's why I found it interesting that she mentioned semaglutide because first of all, it's hard to say. Second of all, like everyone's familiar with Ozempic. And just for our listeners, like if you're just tuning in, like Ozempic is the brand name drug by Novo Nordisk. It's the pre-filled pen. Semaglutide is the compounded version, or the active ingredient, I should say, the active ingredient in Ozempic and Wegovy. But it's offered as a compounded version mixed with B12 that you could get at different clinics. Ozempic and Wegovy are usually through insurance. And then if you wanted to get it, the brand name out of pocket, it's usually about like $1,500 a month. So that's the only reason why I ask if it's Ozempic or Wegovy or semaglutide, because there's a big price difference between both.
Huge price difference.
So it's interesting if a big star or not a big star necessarily, but like a celebrity like her is admitting like, oh yeah, I'm getting semaglutide. I don't know. It's just kind of funny to me.
You're switching up. You called her a big star, but early on you were like, who's that?
Well, I mean, if she's someone on TV, I don't know her. I'm really not up to date with pop culture as I used to be.
But yeah, good for her that she is losing the weight.
Yeah, absolutely.
I love, by the way, like watching people that are, and a lot of influencers do it, where they like detail their whole semaglutide journey. They're like 10 units this week, 10 units this week. There's like a whole bunch of people that I follow, and I think it's always really cute. And watching them like draw it up and self-administer it, I think it's super brave to be open about your weight loss journey. And I know that regaining weight, whether it's after gastric sleeve surgery or otherwise, can feel super, super embarrassing. Or you feel super self-conscious, like, oh my gosh, I had this huge success story and now I failed. Now I need to jump back on the bandwagon again. But just so you know, this is a very common thing, not just with gastric sleeve surgery, but with losing any amount of weight, particularly large amounts of weight. It's okay that you regain the weight because you're going to lose it now. And that's just what you have to tell yourself now. Like, it's okay. I have nothing to be ashamed about. This is my journey. And oftentimes we want weight loss to be like this. Ooh, look at me making this. You want it to be like this straight down thing, yes. But it really is more like this. And that's okay. So
yeah,
nothing to be ashamed about there.
Right. And I do have some clients that have had this gastric sleeve done in the past, and, they just regain the weight. And it's something that we can help you with as long as you consult with a medical provider getting back on these meds, especially with the gastric sleeve, because there have been instances of what's called gastroparesis. That's when your, stomach gets paralyzed, and it's just, just food isn't going through anymore. So that's why it's important to make sure that you are being followed by a professional, especially if you have history of gastric sleeve or gastric bypass.
Agreed. For this week's supplement question, which supplement might be recommended to support muscle repair and recovery as part of a weight loss or fitness program?
Is it A, amino complex, B, fish oil, C, multivitamin elite, or D, calcium D glucarate?
Today, we welcome Jewel Edmonds, a board-certified family nurse practitioner. She is a graduate of the Johns Hopkins School of Nursing, and she currently works in reproductive health, where she provides contraceptive care, family planning, and gender-affirming care. Welcome to the podcast, Jewel. We're so happy to have you.
Hi,
Thanks for coming on.
Thanks for having me.
We have lots of women's healthy-related questions for you today.
All right, perfect.
Yeah, I think the most burning question on everyone's mind. Can you clarify if hormonal birth control has an impact on weight gain?
Yes, that is a great question, and one that's super common that we answer like so many times throughout the day. And before I continue, I do just want to confirm that the language found in the studies that I used to prep for this podcast, it was studied in cisgender women or assigned female at birth. And this is really just to not exclude our trans or non-binary listeners who may also be affected by these topics as well. There's really no specific link, and no studies exist that really show a clear correlation between hormonal birth control and weight gain. So we really don't have good data that supports that hormonal birth control is a direct cause in a patient gaining weight once they do start. However, certain aspects or active ingredients of the birth control can cause things like fluid retention, which can obviously impact weight.
I wonder why it is, though, that people tend to realize that. I guess if you're on birth control, maybe you're starting a new relationship, and the effects of that, you're eating out more, maybe. So it's just an interesting phenomenon amongst women and when they start on birth control.
Yeah, that's a really good point, because as someone who primarily does contraception, family planning, one thing that I notice about, I don't want to say all of the patients, but definitely most, they're coming to see us at a big time of transition in their life. So they're either transitioning from childhood to adolescence, which of course we know you're going from Tanner stage 2, 3 to Tanner stage 5. You're growing, you're going to be gaining weight. Also, we see a lot of high school students that are starting college, and they want to go to be prepared and get started on a birth control method. And of course, we know in high school, very likely that you have parents that may be preparing a healthy meal for you. You may be participating in sports, and you go to college, you have the dining hall that has so many delicious food options, and maybe you're not playing those sports anymore, and your exercise is only walking from your dorm to your class. So that decrease in physical activity, increase in caloric intake, just in that time of transition can occur. And then also too, we see a lot of women that are going from a divorce to a new relationship, and you're being wined and dined, like you said, eating out more. So again, just those times of transition, right? We might see some weight gain that's already associated just with what's going on, in addition to starting a new birth control.
Is there a water retention component that makes people feel bigger?
Yes, so there is definitely a water retention component. So I feel like when we talk about birth control, the most common one that people think about is the pill, right? So the combined hormonal contraceptive. So that cute little pack, all of the 3 rows are the same color, and you have that 4th row, that's the sugar pills or the placebo pills. It's kind of what I think most people think of when they think of quote unquote birth control. So with those, and that's also one of the most common as far as like a new start or a beginner, because it's really easy. You have control over it. So it's one that people choose when they are like initiating their family planning journey. So it has two hormones, estrogen and progestin, which are naturally found in your body. And sometimes the excess estrogen can lead to fluid retention. Also with progestin. So there are about 5 different types of progestin, and some are more androgenic than others. And so the progestins that are more androgenic, we do also see some fluid retention as well.
And I'm sorry, Jewel, just to pause you, for lay people that are listening, what does androgenic mean?
So androgenic is associated with like testosterone, so what we think of as far as like more of like the male hormones. And we'll talk a little bit more about that when we get into PCOS as well. Yeah. But definitely working with your provider as far as letting them know, like I've been working really hard on my, making lifestyle changes, working, to lose weight, maintain a healthy weight. What pill can you recommend for me as far as the estrogen amount and the type of progestin that can limit or minimize as much fluid retention as possible is a great question for anyone who is on a weight loss program and is also wanting to start a birth control as well. It's called drospirenol. It's not necessarily new, but it's actually anti-androgenic and also has diuretic properties. So that's also super, super helpful with fluid retention. And that's personally the pill that I use, and I love it. So.
But wait, side note, does it make you pee a lot?
Not necessarily. So it's like it's a very low level diuretic. So not like a Lasix type diuretic.
Okay.
Yeah.
That's really cool. They're getting fancy with these birth controls.
Yes, very fancy.
So Depo-Provera, I feel like, I know we were just talking about like weight gain and all things, but I feel like there's always been a perception that Depo can make your booty big, Depo can make you gain weight. Do you know what I mean? If somebody wants to go on the Depo-Provera shot and they're also on a very serious, intense weight loss journey, would you discourage it, encourage it?
If someone comes to me and they say, I'm on a very serious weight loss journey, I'm working really hard to lose weight, or have lost a lot of weight and I'm working really hard to maintain a healthy weight, Depo is not my go-to. I have a very love-hate relationship with Depo. We have like a panel of patients that love Depo. They're usually adolescents or older women, and they just love Depo.
Sorry, just to clarify, Depo is the shot?
Correct. Yes.
Okay.
Thank you. So it's an injection. So it can be either in an IM or intramuscular form, or sub-Q, where it's injected using a shorter needle into the tissues. You come into the clinic every 3 months to get that injection. You also do have the option now to do the sub-Q Depo injections at home. Once you get educated by your provider how to self-administer at home, it's a great option for self-managing your Depo. But yes, it is an injection every 3 months in the office.
That's really cool that you can take it at home.
Yeah, right?
I can remember being a waitress and having like other young waitress coworkers that were like, girl, I got to get my booty shot today, but I can't because the bus isn't running. Do you know what I mean? It was a whole thing. And I'm sure that led to many a pregnancy. So that's really cool that you can take it at home.
Yes. So now the only thing is like insurances, they can be very stinky about paying for the sub-Q option.
Of course.
Sure. So. Is it also 3 months for sub-Q? If
Correct.
you do it at home?
Okay. Yes, also every 3 months.
But not your go-to if somebody wants to like lose weight.
Correct. Not my go-to. One thing about the Depo is once you give the injection, it's in. If I can't take it out. However, if someone starts a pill and they feel like maybe they are having a lot of fluid retention and they are seeing that weight gain, or they're not liking the pill for whatever reason, same thing with the implants and the IUDs. Even though it is like procedure based to place and remove them, they're so easily removable. However, with the Depo, once it's injected, it's in. So you're kind of stuck with those side effects. And Depo is very long lasting. you're stuck with those side effects until it wears off. And so it's effective for 15 weeks, but it's actually like longer lasting in the body for longer than that. We're just not sure as far as contraceptive effectiveness after 15 weeks. So you're stuck with it for some time. So if someone is on a weight loss journey, it's definitely not my go-to. And the reason being is, so the data definitely shows that if you start Depo younger, so in adolescence, you're a little bit more susceptible to weight gain, but about 5 to 10 pounds on average in users we do see. The progesterone increases the appetite.
I see.
Did you guys used to kind of hear that, like old wives' tale? People used to say, like, "Oh, if you're on Depo, your booty's gonna get big." Like, did you guys hear that when you were growing up, or no? Just me?
I did not know. And I hear a lot of patients say it. So I think it comes from it being an IM or intramuscular injection. So the common places where you can get it is either your deltoid or your gluteus maximus. So I think there's some thought that if the Depo goes in the glute, and a lot of people like it in the glute because like you're not walking around with a sore arm all day. I think there's some thought that the medication like goes straight to your butt and makes you gain weight in your butt.
Interesting.
I mean, Depo is not all bad. We do see a high success rate of what we call amenorrhea or period stopping. So it's very helpful for someone who may be having like what we call heavy menstrual bleeding, or someone who we may not want to get a period. Maybe they have a disability, any sort of like issue, or if they also can't do estrogen. So we can talk about, some folks who may not be appropriate for an estrogen containing birth control. Depo is a great option.
Great. So I was curious, like, what medication would you recommend for someone who wants birth control, but they just don't want weight gain?
First, I like to ask patients, like, what is your goal with birth control other than obviously not getting pregnant? Is there anything else that you're looking to get out of it? Is it regular periods? Is it less acne? Is it maybe to not have a period? And also, are you okay with the idea of taking a pill every day? Are you okay with the idea of having a procedure to place and remove this birth control? So starting from there. And then also too, would you be interested in a non-hormonal option? Is that something that you would feel a little bit better about as far as like just managing your weight goals while still having an effective form of contraception?
So I like that. I like that you consider different goals that they're trying to look for rather than just kind of like being like, well, you know what? I like this one actually, honestly, for you. But yeah, like you said, it really just depends on what they're looking for in their birth control. What advice would you give to someone who's looking into non-hormonal birth control, but they're concerned about the side effects like increased menstrual cramping with the copper IUD?
Yeah, so the copper IUD is a great non-hormonal option. It's super effective, and it's great for patients who don't want hormones or medically can't have hormones for whatever reason, and also are really concerned about how those hormones may affect their weight. So the copper IUD, it's a what we call a LARC, or a long-acting reversible contraception. It's a T-shaped device, and it's placed in the office by a nurse practitioner, PA, MD, DO. And so how it works is the copper creates like a sterile inflammatory environment in the uterus, so a pregnancy can implant. And it also acts as kind of like a kryptonite against sperm. It's effective for up to 12 years. It's approved for 10. It's about 99% effective. However, we do see it can change your periods. So we can see more cramping and heavier bleeding and longer periods. So usually patients that are getting a copper IUD, I usually start off the appointment by asking, what are your periods like at baseline? Are they super awful? Are you having to call out of work because your periods are so bad? Are you not able to like hang out with your kids, run an errand on the weekend, go to class because your cramps are so bad? And if that's the case, usually I'm like, maybe we should talk about another method. But if someone is like, oh, my periods are great at baseline, it's like, okay, we're good to go. But as far as managing the crampier, heavier periods, NSAIDs are super effective. So high dose NSAIDs. So think ibuprofen, 600 milligrams, 800 milligrams 3 times a day. Also get that heating pad out. Heating pads are great for that uterine crampy type pain. Also kind of just anticipatory guidance. So letting patients know that this is an expected side effect, something that's not like you're not dying, it's normal. And just like setting that expectation. And then also too, this should taper off or start to improve about 3 months after the IUD is placed. And just letting them know too, this is when too much bleeding is occurring. So if you're soaking through more than one pad within an hour, you're feeling dizzy, lightheaded, don't feel the need to wait 3 months. Come in and see your provider right away.
Jewel, there used to be a thought that if you had an IUD, you had to have had a baby. That used to sort of be what the thought process was, you know, like, oh, like I can't get an IUD, I don't have any kids. Is that still the case, or is it still an option if you've never had kids before, but you want all the, you know, benefits of having an IUD?
That's a great question. I'm so glad you asked it. So absolutely not. If you are what we call a nullip or nulliparous person, you've never had a baby, never been pregnant, you can still totally get an IUD. You're eligible for either hormonal, non-hormonal. And the theory was that if you hadn't had a baby yet, your uterus was too small for an IUD. That is not true. However, we do see a little bit slightly higher rates of spontaneous expulsion where your uterus is just kind of like, nah, pushes the IUD out. But the data isn't so high where it's like we would tell someone that they can't have an IUD.
Birth control options aside, if I'm struggling with weight loss or weight gain, how do I know when to see my women's health provider?
Right away. If you have any questions just about maintaining your weight, as far as like you're concerned about just unusual weight loss or unusual weight gain, it's always a great time to check in for several reasons. Just making sure that this isn't related to something like PCOS, an endocrine condition, also other endocrine conditions like hypo or hyperthyroidism that can also affect your reproductive health as well. So if you're having unusual weight loss or weight gain and you're also feeling super tired, you're having acne, you see like weird hair loss or weird hair growth, and also irregular periods, check in with your GYN or women's healthcare provider right away.
Okay, so basically if you're having this weight gain in conjunction with like a change in your period or like some other type of thing that would be GYN concerning, you should go to a women's health provider.
Yeah, absolutely. A
lot of people, when they're on their period, myself included, get super, super hungry, or they want to eat all the things. And I get a lot of patients, like everything, carbs, chocolate, chips, all like everything. And I get a lot of patients who are like, well, do I give into those cravings? Do I not? Like what's the best way to manage having those cravings? You know, like, is there any benefit to giving into those cravings? Are these actual real hormonal imbalances that are making us hungry and have cravings? Please weigh in.
I wouldn't say it's necessarily a hormonal imbalance. It's just like your natural hormonal changes due to your cycle, just kind of make you want the salty things, the sweet things. It's totally normal. What I would say is to manage those cravings, especially if you are on a weight loss program, probably things that you already tell your patients: drink lots of water, so staying hydrated, getting lots of fiber, doing the things to help you feel full so you're not hungry to where you are likely to indulge in the sweets. And also decreasing your things like your caffeine intake, sugar intake, alcohol intake. And that overall just helps with all other PMS symptoms as well. Getting lots of protein and complex carbs. And I say totally okay to indulge. Make sure you're getting your bang for your buck. So make sure that it's something that like you really enjoy. Like, don't go for the, I don't know, the low fat thing that's kind of like, like really make it something that you enjoy. Everything in moderation, including moderation. So, just make sure it's super satisfying. So something like really good and flavorful, just to curb those cravings will help.
Is there any
Thank you.
truth
That is very helpful.
like when you're on your period, like are you expending more energy and therefore can like eat more?
Yes and no. So definitely like shedding the lining of your uterus, like it's a lot. Building it up, it's a lot. So certainly like you can add a couple more extra calories like during that time. Won't hurt and won't, totally derail a weight loss program.
Okay.
Yeah, especially since a lot of our clients are women, and like whenever we check in with them, they do, say, I do feel the cravings come on, but it's probably my period, so they are aware of it. But it's also good to know that like it's fine. It's fine for you to have the bag of chips and have some ice cream. Totally okay.
Agreed. And as an aside, I totally agree with you about making it count and making it something good. I'll have people come in and what are those sweet things? It's like pretend candy, like diet candy you can get from like GNC. And they'll be like, oh, I got like this, whatever. I ate the bag and it kind of tastes kind of like licorice. I'm like, girl, just eat a Twizzler. Eat a Twizzler. You know what I mean? Just eat one Twizzler and enjoy it instead of eating the substitute that you clearly don't like because you're wrinkling your nose as you talk to me. Like just eat. If you're gonna spend the calories, spend it on something that you actually like.
Yes. Yeah. Or do either you like that Halo Top ice cream?
No, I tried it once. No.
It does not do anything for me.
Same. I tried it. I'm like, what is this? So I like don't buy the Halo ice cream. Buy the Talenti. Have like a little, like a small cup, a small serving. Like that will satisfy you.
Get you some caramel crunch.
Right. Exactly. Yeah. That will satisfy you way more than what the whole pint of that Halo was.
So moving on to Ozempic babies.
Ozempic babies.
Oh, yeah. So with no current data available, what concerns should patients have about Ozempic affecting birth control effectiveness?
This is a great question. And I loved like the previous episode, Katie, when you mentioned the Ozempic babies, because I was like, oh, this is right up my alley.
Yeah, so there's been all this stuff about Ozempic babies. It's been all over TikTok, in the news, even on TV, where basically a lot of women are coming forward and being like, hey, like I got pregnant on Ozempic.
So you guys are on like such the like forefront, cutting edge, working with Ozempic. It's such a new medication. All of these are so new. So it's so exciting, I think, to be involved in this field. However, we're still learning about it. So as far as how it affects things like birth control and fertility, so there's really not much data available, but as far as birth control effectiveness, it has to do with how the Ozempic works. The mechanism of action, and correct me if I'm wrong, is to slow down the digestion. So theoretically, this can affect absorption of things like birth control pills, so any oral birth control medication. So the pills may not be absorbed as effectively due to the delayed gastric emptying. As of yet, there is no published research between the relationship between Ozempic and as far as the effectiveness of birth control, but it would still be wise to maybe consider a non-oral option. So that would be anything like the birth control patch, the NuvaRing, which is the vaginal ring, an IUD, an implant, and very cautiously things like the depot as well. And this is super important, I think, just politically what's going on. We have a couple of states that are like banning abortion, depending on like what happens with the election, we may see some further restrictions on reproductive rights. So very, very important to have a talk with your patients that are starting Ozempic. How do you feel about pregnancy? Are you using a reliable form of birth control if you do not wish to be pregnant?
I think that's a really important thing to bring up because patients are so excited to lose weight. I feel like sometimes it's really easy to kind of like gloss over the what about your birth control conversation. But it's very, very important.
Yeah, and that's something I had to bring up to a client actually, because she did have that question for me months ago, and this was before all this Ozempic baby stuff came out, and so I was like, "Oh yeah, you're fine." And then when that article came out, I'm like, "Girl, you gotta use a backup method." I'm so sorry,
Yeah.
but yeah, this came out that people are getting pregnant off of Ozempic, and they're using oral birth control. So it's just really important as a provider to double check the meds that your patients are on, and to let them be aware of this stuff, because we're learning stuff every day about Ozempic. So it's just to do your part and your due diligence to let your patients know.
Yeah.
And similarly, Jewel, in terms of what we're educating patients on, is there an actual time frame we should be telling them for those that want to get pregnant, in terms of how long they should wait after going off of Ozempic to try to get pregnant?
Yeah. So semaglutide is considered pregnancy category C. So all of the medications are categorized as far as A, B, C, D, and E. A is no risk. And then D and E are like, do not use in pregnancy due to the risk that it can have on the fetus. So it's Ozempic or semaglutide is considered a category C. So what that means is that overall, it should only be used during pregnancy when there's potential benefits that outweigh the risk to the fetus. And the reason being is it can cause some birth defects, low birth weight, and also increase the rate of miscarriage. Generally speaking, everyone metabolizes medications a bit differently, but overall, most healthy adults are going to metabolize Ozempic out at about 6 weeks. And generally, the guidance right now is to stop at 2 months before getting pregnant.
Okay.
Also, you want to counsel these patients that do stop to start taking prenatal vitamins if they haven't already done so. Get that extra folic acid in. Super important.
It used to be that should women of childbearing age just be taking them just in general?
Yes,
Yeah.
they actually should. Yes.
Cool.
Yeah, and then I also had a question too, say, someone gave birth already, and then they do want to go back on a weight loss journey. Do you have any suggestions as to what time frame that should be and what medications they should be taking?
I would say definitely make sure that you've done your 6-week postpartum visit, and also you've had the conversation with your OB as far as your plan for contraception and family planning moving forward. And then also, are you breastfeeding? It's not recommended to use Ozempic while breastfeeding as well. So all of those things considered, okay to start after kind of all of that sorted out.
And what about, I'm not sure if you're familiar with the oral meds like phentermine or any of the stimulants. Is that recommended postpartum?
I would say I am not quite sure. I know with phentermine it can raise the blood pressure. You're at slightly higher risk, directly after having a baby for those cardiovascular events, blood clots, those kind of things. And I'm not sure how it affects lactation either. So
Got it.
That question, I'm not sure, but I can get back to you on that.
No worries. Thank you.
Those are really good questions.
Yes.
Even as a clinician, I'm oh yeah, I maybe I should be collaborating more with women's health providers when I get these patients that are postpartum, because what if girlfriends had preeclampsia or eclampsia and it's you know what I mean? Sometimes patients don't see the connection, but we're worried about your blood pressure for a while after you've given birth. And you're absolutely right, phentermine can raise your blood pressure. Can we talk a little bit, when we're talking about Ozempic babies, about the whole fertility piece? We had kind of alluded to it a little bit in a prior episode where we were kind of okay, people, maybe it's a change in fertility because you've lost weight. So some of these other disease processes have gotten better, like your PCOS or other things. But do you have any sort of thoughts about Ozempic and its impact on fertility?
Being obese or being overweight, it doesn't mean that you can't get pregnant. However, we with healthier weights, we do see increase in fertility. So with obesity, that can result in excess estrogen, and that higher level of estrogen can lead to irregular menstrual cycles, which can cause irregular ovulation, making it difficult to get pregnant. Also, we can see increased insulin resistance and some higher levels of testosterone that can make getting pregnant difficult as well. And hence the Ozempic baby. So after you do lose a certain amount of weight, we can see those hormonal imbalances corrected and fertility increases.
So, Jewel, first of all, what exactly is PCOS?
So PCOS is super common. It's probably the most common endocrine abnormality in women. It affects about 5 to 10% of women. So the common kind of like clinical picture, what you'll see as far as like symptoms are going to be irregular periods, hyperandrogenism. So think things like hair growth in places where women typically don't have hair, like upper lip, chin, chest, obesity, glucose intolerance, and dyslipidemia or high cholesterol. So these patients, they'll usually have less than 9 periods a year. We'll see things like acne, again, that hair growth, chin, chest, upper lip, and then sometimes even hair loss in like the male pattern. So like thinning along like the hairline and crown of the head as well. Also, fertility can be an issue. So we can see anovulatory cycles, and also weight gain or weight management can really be a problem. So about 40 to 85% of women with PCOS are overweight or obese.
And is it because is being overweight or obese causing the PCOS? Or is it like having PCOS makes you gain weight?
What came first, the chicken or the egg? It's like one could, the other could as well. There's really no clear answer.
And in your experience, like clinically, who are you usually seeing have this disease process? Like, is it kids? Is it like women in their 30s? Like, who do you see more commonly getting this diagnosis?
It varies. I mean, most commonly, like the age group that we see where I practice, it's like early 20s, late teens, but mostly early 20s, mid 20s. We can see early 30s as well, kind of when those fertility concerns start to kind of pop in. So,
and I'm sorry,
real quick.
Oh, go ahead. I think we're about to ask the same thing, which is, what does it stand for?
Yes.
Sorry, I'm so sorry. So PCOS is polycystic ovarian syndrome. And it's called that because so there's a couple ways to diagnose it, and I can talk about that in a bit as well. But one of them is getting an ultrasound or sonogram to look at your uterus, your ovaries, your fallopian tubes, and classically what they see is what's called a string of pearls as far as what the ovaries look like, hence the term polycystic. So you have enlarged multiple ovaries seen on the ultrasound.
Is it painful?
It's not painful. However, the periods can be awful. So when they do come, they're usually irregular, so less than 9 a year. But when they do come, they're usually pretty awful. So a lot of pain, a lot of cramping, a lot of bleeding.
And weight management plays a crucial role in managing the PCOS. Could you discuss some of those successful lifestyle interventions that have shown promising results?
Yes. So overall, the goal with managing PCOS is we want to just ameliorate all of those symptoms. So get regular cycles back, work to reduce acne, work to reduce those signs of hyperandrogenism, so the hirsutism, addressing those things. And the data supports that healthy lifestyle is like first line. So things like diet, exercise, and then also we can use things like hormonal birth control as well to help regulate the periods. And also endometrial protection with these patients is going to be super important. So if someone is not on any hormonal birth control and they're not getting a period, we're concerned about what's going on with the lining of that uterus. Since it's not coming out in the form of a period, it's building up. And so that can put people at risk for endometrial hyperplasia, which can lead to endometrial cancer later down the line. So endometrial protection is super important, but definitely lifestyle modifications as well.
Have you had any experience with women that are on these GLP-1s, so like semaglutide, tirzepatide, who also have PCOS?
Personally, no. I have referred several patients to like weight management clinics or a nutritionist just to get help with like getting the ball rolling on this process. So patients, especially that are not interested in hormonal birth control, I have definitely encouraged like seeing a weight management specialist or nutritionist just to get started on maybe starting a GLP-1 or just getting counseling with healthy diet and exercise.
I know metformin's been used in the past with PCOS. Is that still commonly used?
Yep, so it's still an option. It's a great option for, again, someone who is not interested or does not want to take a hormonal birth control or medically may not qualify for a hormonal birth control.
How does metformin work with PCOS? Like, what's the mechanism of action there? Because that's typically a diabetic drug, right?
Yes. So it works with the insulin resistance. So we can see reduced in, I guess, kind of with the reduction in the testosterone, helps with weight loss. And so we can see return to regular ovulation.
Okay. So I guess it's similar to what like semaglutide would do too, because I've also read about that link with the helping with the insulin resistance and then helps also with symptoms that patients get with PCOS. So yeah, really cool.
It is really cool. And maybe the GLP-1s might yield some higher compliance because I know the GI effects of metformin, a lot of people don't want to deal with. And just the fact that a lot of these women are young, they don't want to take a pill once or twice a day.
Right.
Yes, definitely adherence is a big one.
And so I think Zarina and I can both agree that women that come into our clinic are either coming in immediately being like, girl, I am menopausal. I'm getting hot flashes. I know that's why I can't lose weight. It's definitely that. Help me. So we're getting a lot of that. And then I also get a lot of patients that are throwing around words like women that are like 30s, 40s, throwing around words like perimenopause. And so can we talk about sort of what happened? First of all, can you define for us what perimenopause is and what age range is that? And then what menopause is?
Yes, so perimenopause means around menopause. So this is around the time when the body starts the natural transition from being fertile to marking the end of your reproductive years. And so this is when all of the hormonal changes start to begin and we start to see those vasomotor symptoms. And the onset of perimenopause is different for everyone. Generally, it can happen as early as your late 30s, early 40s. And really, a lot of this is going to be kind of on an average. So, and menopause is that, so that's 12 consecutive months that you've gone without a menstrual period. So you've gone one whole calendar year, no bleeding, no vaginal bleeding at all. So that's menopause. So it's going to be different as far as, the timing for everyone. In the United States, average age ranges could be between 48 to 55 for menopause, but generally the average is about 51. Also, it has a lot to do with kind of like your family history. So if your family started like mid 40s, so your mom started mid 40s, your sisters, aunts are, kind of all started to transition in mid 40s, you can kind of anticipate that you'll transition around that same age as well. Same thing like with anyone who's, mom started 56, 57, you can kind of anticipate around that time as well. But there's lots of hormonal changes going on at that time.
I think for Zarina and I, when these patients come in, and they're like, oh, I think I've hit menopause. My periods are really irregular. I'm getting hot flashes. Are these sort of what we would consider the early signs of you're about to hit menopause?
Yeah, absolutely. So definitely the irregular periods, definitely the night sweats, definitely the hot flashes. As far as like definitive testing, so there was some thought that testing the FSH level, so that's your follicle stimulating hormone, It's so variable. It's really not as valuable as what it was once thought to be before, but definitely like those subjective findings of hot flashes, night sweats, irregular periods are going to be the best way to kind of diagnose menopause.
And I have a lot of my clients that are going through menopause, and they're pretty healthy ladies before they had menopause, and once they hit it, they're just like, I can't get rid of this extra 15 pounds that I've gained. So I just wanted you to talk about like what are the factors that contribute to this weight gain once they hit menopause.
Yeah, there's so many factors, and it's definitely frustrating. But please let your patients know it's a lot of things that can contribute. Hormonally, what's going on is we have a decrease in estrogen levels, and that's because the ovaries aren't functioning as they once were during reproductive years. So we have a decline in estrogen production, and so this results in an increase in androgen levels. So kind of like what we think of as far as more male hormones. So we have this hormonal imbalance, and this can also change your energy homeostasis, which can change your hunger and also like your signals as far as like wanting to eat. So the estrogen, it does have an action where it does inhibit hunger signals, to prevent excess caloric intake. And so once we have that decrease in estrogen, we can have menopausal women experiencing more intense hunger signals, which can increase your food intake, resulting in weight gain. So yeah, your patients they're not crazy. This is real. This is very, very real.
So normally we have a certain amount of estrogen, and then when you're going through menopause, and the estrogen helps make us not as hungry. And then when you go through menopause, you start to lose some of that estrogen. So you're getting hungrier.
Yes.
Got it.
Correct. And then also to keep in mind, like with menopause, other things that are going on around that time. Generally, like you may just see like a decline in physical activity at that time. Again, like just those like normal life changes. So my mom is getting ready to have both knees replaced. So you may have some musculoskeletal issues. So things like joint pain, hip pain, that can impact your ability to exercise. So maybe you're not able to run, walk, work out as much as what you were before. Also, just we have a very like processed American diet that can really impact just weight changes related to menopause. These are patients where they're new empty nesters, so instead of having to like come home, cook healthy meals for a kid, that kid's now in college. Now it's like, yeah, like, okay, maybe it's okay to eat out a little bit more, or order takeout for dinner. And just like there's a lot of psychological stress, right, with transitioning from like being in the workforce or being a caregiver to a kid, and kind of like your role has changed. So definitely like some stress that can contribute to some emotional eating as well.
Yeah, that makes a lot of sense. Aside from it being a hormonal thing, sounds like just your life circumstances have changed too. So I was wondering, could you offer some effective strategies or treatments for managing weight during this life stage?
Yeah, so again, most of the data does support just non-pharmacologic, both a non-pharmacologic and pharmacologic approach. So low calorie diet, increasing exercise as first line, and then considering pharmacologic management for patients who might not be successful with that. So things like a 500 to 750 calorie or daily calorie reduction can be helpful. So increasing protein intake, of course, limiting like salt, processed foods, sugars, and about 150 minutes per week of moderate exercise. So of course, something low impact and getting good bang for your buck. So walking is really helpful for those vasomotor symptoms, and also yoga is really going to be helpful for those hot flashes and sleep issues as well. Strength training to help your bones.
Yeah, I was about to say, especially during that time, like, because estrogen really helps with that, right?
Yes.
But then when you lose it, then you're at more risk for osteoporosis and fractures. So really good to incorporate some weight-based exercises, weight-bearing
Joel, I
exercises.
wonder if people listening to this are thinking to themselves, well, if estrogen is the problem, can't I just take estrogen to solve the problem?
Absolutely. So, hormone replacement therapy is definitely an option. Very important to discuss it with your GYN primary care provider because it certainly has risks, in and of itself. But hormone replacement therapy can be very, very helpful with managing those symptoms of menopause, especially vasomotor symptoms. We love vaginal estrogen in the women's health space. It's super, super effective for managing those like genital urinary changes that also naturally occur due to the decline in estrogen. Vaginal estrogen, super helpful. So just having a conversation about like, what is your biggest concern? What would you like to address? Generally, the guidance as far as hormone replacement therapy, start low, go slow, and then slowly titrate up as needed.
And for these women, do they who are saying like, I don't know, maybe I need some estrogen, this menopause life is really tough. Do they need like lab work when they come to see you? Like do they get a vaginal exam? Like what does that visit look like?
Yeah, so definitely it should start with getting some labs. So definitely we want to check things like your lipids, assessing cardiovascular health. So making sure that your blood pressure is in a good range. Also asking about any sort of like contraindications to estrogen. So things like an undiagnosed or unworked up breast mass. So these are patients we want to make sure they're up to date on their mammogram and breast exam. Also, just generally making sure that they're up on just all like cancer screening. So have they had their colorectal screening? Are they up to date on things like their pap smear? Have we done a brisk assessment? So assessing family history for things like breast and ovarian cancer. And as long as those, we can determine that it's appropriate, it's safe, talking about goals and, as far as the route, the dose of starting hormone replacement therapy.
Women seem to think that weight loss itself is harder because they're going through menopause. I know that they're having appetite changes, but should losing weight in terms of like a hormone metabolic standpoint, like should that be hard?
It is. It is going to be harder. So overall, just at that point in life, adiposity or just holding on to more fat, it's just favored at that point in life with the body. So it's definitely going to be harder. And again, just with those hormonal changes. So also with increasing like androgens, we see increase in abdominal obesity. So it makes you kind of store weight more in like your midsection or the abdomen. So that change in body composition, difficulty losing weight, it's real, definitely a real thing.
If only we could stay young forever.
If only.
Men have it so easy.
Right.
They really do.
Well, thank you so much, Jewel, again, for being on the podcast. We appreciate it. I don't know if you have any social media that you wanted to share with us that we can plug for you or.
Yeah, I'm not too big on social media, so I don't have any to share. Okay. If you want to follow my pug's Instagram.
Sure. We'll link it.
And follow Prince's adventures through Baltimore and just being the cutest little pug ever.
He is super, super cute. Also, Jewel is like a Peloton nut. Myself too. So she's super fun to like ride on Peloton with. She goes, how many rides have you done now, Jewel?
I just I recently got inducted into the Comma Club a couple of months ago. So that was very exciting. But
wow, congrats.
And for those of you who don't know, who don't speak Peloton, that means she's done it. Girlfriend's done 1,000 rides.
Wow.
That's what the Comma Club means.
So, and I totally have Katie to thank for that because she not only introduced me to like the app and just Peloton in general, but also like really encouraged me to get the bike. So thank you so much for introducing me to that like healthy lifestyle. And also it really helped me on like my own weight loss journey. I probably lost about definitely like 20, 25 pounds since starting Peloton. So
Oh, that's amazing.
You look amazing.
thank you.
Super amazing.
I love that.
And it's in her blood too. Her mom is a bodybuilder. How cool is that?
Wow.
I'm throwing all Jewel's business out there, but it's so cool.
That's so cool.
But no, it's been super fun to ride the bike with you. And I selfishly did it because I wanted my best friend to ride Peloton with me. But you're such an inspiration. You're so smart. I'm so grateful that you came and hung out with us on this podcast. This was super helpful.
Yes, thank you. This was fun. Thank you both for what you're doing. This is such great work, so necessary in the community. And I think it's just such a great way, I think, to show like how weight management and women's health, we can really work hand in hand just to get patients the care that they need.
Absolutely.
Yes, for sure. Thank you. This week's answer to the supplement question is A, amino complex.
The amino complex is a blend of essential amino acids, which are vital for muscle repair and recovery, especially after exercise. During weight loss or fitness programs, supporting muscle health is crucial, as muscles are integral to a healthy metabolism and weight management. Amino acids can help prevent muscle breakdown, support muscle growth, and improve recovery times. While fish oil offers anti-inflammatory benefits, multivitamin Elite provides broad nutritional support, and calcium D-glucarate aids in detoxification, none are as directly impactful on muscle repair and recovery as the amino complex.
Remember, supplements can be a great tool when combined with a healthy lifestyle. Always consult with a healthcare professional before starting any new supplement regimen.
Both Serena and I are delighted to be affiliated with Thorne. For top quality, safe supplements, simply visit our website, www.thewhnps.com, and click on the Weigh-In store to explore either of our vitamin shops.
If you've enjoyed today's episode, please take a moment to subscribe to our podcast, give us a rating, and share with your family and friends who might find it helpful.
And remember, we love hearing from our listeners. Connect with us on our social media channels or shoot us an email with your thoughts, questions, or suggestions for future topics. Don't forget to check out our website, www.thewhnps.com, and to follow us on Instagram at thewhnps.
If you need one-on-one help with your weight loss or wellness journey, book a private consultation with us. The A-List Clinic can be reached at www.thealistclinic.com or on Instagram and TikTok at the A-List Clinic.
And my clinic, Lifefire Weight and Wellness, can be reached at www.lifefireweight.com or on Instagram and TikTok at lifefireweight.
Thanks again for tuning into the Weigh-In Podcast with your hosts, Katie and Zarina. Until next time, take care and be well.
The information in this podcast is for general information only. It is not intended as medical advice and should not be relied upon as a substitute for medical consultation with a qualified medical provider familiar with your medical needs.